Good morning, everyone. Thank you for joining the webinar. Let me start with the housekeeping role. The webinar link will be available from 9 a.m. to 9:45 a.m. to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to NCCPD guidelines. This is to improve and maintain the standards of the CPD program conducted by SHRI, thanking you for the strict adherence of the CPD regulations and your kind compliance. I would like to request to you, all of you, to switch off videos and keep your mics on mute. I kindly request you to type in your questions in the chat box. We can discuss on those after the webinar. Please change your chat settings to all panelists and attendees so your question can be answered. If you have very specific questions about your situation, please email us on officeshri13@gmail.com. I hope all of you will enjoy this webinar and find it very useful for your clinical practice. Without any further delay, I would like to welcome our lecturer for this webinar session, Professor Madhubhashinee Dayabandara, Consultant Psychiatrist, Faculty of Medicine, University of Colombo, National Hospital of Sri Lanka. Over to you, madam.
Thank you very much for your kind introduction. I hope that everybody can hear me. And I will share my screen. So the topic today is managing delirium in medical setting. I thought this would be particularly useful for many of you because delirium is something which is not restricted to any particular medical setting. It's found in outpatients, it's found in inpatients, and in almost all the medical settings: surgical, medical, gynecology, obstetrics, pediatrics, psychiatry, all the settings, we can actually find patients who are delirious and who need acute attention. I have actually shared an MCQ at the beginning. So let's go through that. And it's basically for you to identify some concepts during the webinar, and then you might be able to understand the concept behind this particular MCQ stem at the end of the session. So the first one is that delirium is a medical emergency. I wonder if you agree with me or not, whether it is true or false. That it is, second one, best managed by high-dose antipsychotics. I would like you to, think about what you would answer for that. Is it true or false? That it is known to occur with subacute onset. That it is characterized by poor attention, and it is common in the elderly. So let's see how you might think about these stems as we go along. I'd like to start off with 3 case scenarios. The first one is of a 75-year-old male admitted to medical ward with chest pain. Subsequently, the patient was transferred to the CCU for management of a myocardial infarction and subsequent heart failure. Third day in the CCU, he was noted to be irritable and agitated. He didn't sleep in the night, didn't know what time of the day it was, and became rather scared when a nurse approached him with an injection, and he had to be told that it is that it was a medication, and he became reassured with that. These were the only symptoms that he was having. The next patient, so is this a delirium or not? I think that most of you would agree that this is very likely to be the presentation of a delirious patient. But this is not the picture that we see in many of the patients with delirium, and that is the problem with identifying delirium. The second case is of a 5-year-old girl having high fever. She didn't take food, but mother ensured that she took enough fluids. And during the fever spike, she started crying and said she saw genies. Actually, she was saying, "Bhutayo wahaleng enawa." And, she was terrified and she was talking incoherently. The mother actually could not identify what she was talking. She said that, the little girl was talking gibberish. So, is this a delirium? We often see young people, small children, very often, getting confused during fever spikes. What is the likely outcome for this child if it is a delirium? Let's discuss. Then there is a 65-year-old female who had been previously functioning well, admitted for IV antibiotics for an acute pyelonephritis. In the ward, she was noted by staff to be sleeping all the time. So they said that the patient is not a problem at all. And nurses are really happy when, the patient is quiet and, minds her own business. And, but when, when the medications were to be given, she took time to realize where she was when she became awake and appeared distractible. And sometimes the nurses said she is in a world of her own. She doesn't know where she is. They wouldn't worry too much about her. But after a few days, she got better. She reported she could not remember what happened during the ward stay. But the children, during the subsequent clinic visits, actually started complaining that she had actually been forgetful after returning from home. And they said, before she got admitted for treatment for the infection, that she did not have any cognitive impairment. And they said that, this is a new thing. And they were worried that this might be something linked to the kidney infection. And they were asking the doctor what to do. And the doctor was puzzled as to what had happened. So can delirium actually cause lasting cognitive impairment? This was not something which had been identified when I was a medical student and when I was an intern medical officer, or maybe even a medical officer in my early career days. We thought that delirium was not something, it was something very acute and transient, and that it could not cause long-term cognitive impairment. But now we know that it is not, and that it can actually on its own cause cognitive impairment in the long term. And let's see why this happens. Okay, so for the information, for most of you who might not be very familiar with the diagnostic criteria for delirium, it comes under the, the ICD-10F chapter, where all the mental illnesses are included. So therefore, you might not be very familiar with the concept, even though it is a concept which all doctors should be familiar with. You can see that the diagnosis with regards to ICD-10 for delirium is rather restrictive. It needs one symptom from each area out of 5 areas. Can you see? The first one is impaired consciousness and attention. So they should be having some level of impairment of consciousness and attention deficit. And the second one is that there should be some global disturbance of cognition, that may be in perceptual disturbances such as illusions or hallucinations, maybe some persecutory ideation, paranoid ideation, maybe overt delusions, maybe some confused thinking, some memory impairments. So there should be some global disturbance of cognition. Then psychomotor disturbances can vary from a patient being a little bit agitated to very, very restless and violent. And, recently I got a call from a medical ward with somebody who was in delirium tremens, and the patient, despite the consultant and all the other team had, tried to, sedate the patient, they could not actually manage the patient, and he was very violent and had to be physically restrained. And we were actually consulted to help out with the sedation. On the other hand, he is a very hypoactive sleepy person, like in the third case scenario that we were discussing in the very beginning. The first one you remember was the agitated old man who suffered a myocardial infarction. The second one was the small girl. The third patient who was not at all problematic, she just kept to her bed. So somebody might actually be comatose, but somebody in coma is not considered delirious. So actually being in a coma would exclude the diagnosis of delirium by nature of the diagnostic criteria. But beyond that, you would know that impaired consciousness would come into place. And psychomotor disturbances can vary from being very hypoactive and inactive from a subacute delirium into a very overtly restless, violent patient. Then, of course, the sleep-wake cycle disturbances become common. They can actually stay awake and restless during daytime, and then they might actually, they might be sleeping during daytime, and then they might be restless and awake in the night. So there is some reversal of the sleep-wake cycle. And emotional disturbances, they might be fearful, they might be very anxious, they might be crying. So emotional lability is seen very often. So if you have to have one from each area, there are 5 criteria, isn't it here? And ICD-10 is rather restrictive in that, even though it's very descriptive, and you can get a good idea by what delirium really means by using the ICD-10. Therefore, most of the clinicians now stick to the DSM-5 criteria, where only 2 things are needed. You need a disturbance of attention and that it should develop over a short period of time. Now, I got several very relevant and pertinent questions before from the organizers. You had forwarded the questions to them. And one question was, how are we going to distinguish somebody who is suffering from delirium from a patient with dementia? And this is the trick. In delirium, the symptoms should develop over a short period of time, and you have to know the baseline of the patient. And that's where clinicians find it a bit difficult, because they wouldn't know a patient who had been admitted for the first time in their unit. So we'll discuss that later. Then they say, look, additionally, there should be some disturbance in cognition, such as in thinking and, perceptions and cognitive functions. And they say it should not be explained by a pre-existing condition. This is to avoid some confusion with dementia or any other condition, maybe substance intoxication and withdrawal, and that it should be due to physiological disturbances. 5 criteria is what is usually used. Just remember 2 things for delirium. There should be some disturbance of attention. It should have developed over a period of time, and there might be additional disturbances in cognition. If you find that somebody is distractible, somebody is not really there, somebody who is confused, then suspect a delirium. That's the message to take home. How do you differentiate delirium from pre-existing dementia? You will find that the patient will give a history, or the relatives will give a history, where the patient has been having gradually deteriorating cognitive function over maybe few months or few years. But then they would say, look, but over the last few days, the patient suddenly changed. He became very active, very restless, and started saying things that that he or she did not say previously. Or else they would say, look, she was up and about, and she was eating, she could not recognize a lot of people, but she was okay, and she was making conversation, and then she suddenly started to sleep more. She's not responding at all. She's drowsy most of the time. So a pre-existing dementia, the collateral history would indicate some cognitive impairment has been there, and that it is stable, and that it was probably deteriorating in a very slow fashion. But a sudden acute disturbance over maybe hours, minutes, or days would indicate the possibility of a delirium. How do you differentiate delirium from psychotic illness? This is another question that I got, and very relevant. Yes, because it's very difficult, isn't it? you might not be able to, assess orientation properly in a psychotic patient because they might be too restless and distracted, isn't it? On the other hand, a patient with psychosis might be very distractible, will not pay enough attention. But then, how do symptoms of delirium differentiate from a psychotic illness? Number one, patients with psychosis only will actually be fairly oriented to time, place, and person. Even though you might not be formally able to assess them, you might actually, you might actually get the impression that patient actually knows where they are. And, they know, their personal details. They know what time of the day it is. Then on the other hand, the symptoms of delirium are very much fluctuating and transient. So they might have a visual hallucination now, but they might not have it in the next 5 minutes. Things are very fluctuant, transient, and fleeting. May තියනවා, may නැහැ. That's the characteristic feature of perceptual disturbances and psychotic symptoms of delirium. Whereas in a pure psychotic illness, such as maybe in a delusional disorder or schizophrenia, they would differ because their symptoms would not usually change over time like that. So whatever auditory hallucinations were there today, they are unlikely to have changed tomorrow unless you have actually treated them, and they are gradually disappearing. But they would not change in form and in content very quickly like in delirium. Okay. So if you have any questions, please put in the chat box. Sometimes in between, I am happy to answer any questions that you might have. What's the prevalence of delirium? It differs. So naturally, in maybe ICU setting, it's very high, as much as 60 to 80%. In outpatient settings, it's less. In nursing homes, it's a little bit higher than in general population. But a good number to maybe just keep in your mind might be that probably 1 in 5 medical inpatients might be delirious. And why do we have to worry about somebody who is delirious? Let's talk about that in the sequelae of delirium. What are the risk factors of delirium? It's nice to think of this as predisposing factors. So delirium occurs in somebody who is vulnerable. And then you think of something which precipitates the delirium, which precipitates the symptoms of delirium. Then, of course, you have post-admission risk factors. Some interventions that we might have done, some medications we might have prescribed, which actually would lead to the delirium. So somebody who is vulnerable, who develops some acute insult, and we have actually imposed some other interventions and medicines on the person, and the patient actually goes into delirium. Graphically, I wanted to make this very simple for you, just for you to have an idea. But I couldn't do a very nice graphic for that sake. But if you look at predisposing factors, which is the most important, because what precipitating factors are there, and probably a lot about post-admission factors which lead to delirium. So let's go through each one very briefly. Predisposing factors, the two ends of the spectrum of age. So very young and the very old and the elderly. Somewhere in between, the risk of delirium is less. Somebody who is having dementia, and why should they be predisposed? Let's discuss when we discuss pathophysiology. If they have a lot of medical comorbidities, and remember, people of low educational level, because they cannot compensate sometimes for the cognitive impairment they might suffer. If they are frail, if they have visual low hearing impairment, and if they are depressed at the same time, if they have, even if they are not intoxicated, and even if they are not in withdrawal, if they have a history of alcohol or other substance use, because, they might already have pathology in the brain and their cognition would be affected by long-term use of alcohol and substances. They might be predisposed to have delirium. And another risk factor is if there is a history of delirium previously. About the precipitating factors, if there's a surgery, infection, electrolyte imbalance, dehydration in somebody who is predisposed, now delirium can be precipitated. And of the most important post-admission factors, pain comes first. Even just, in somebody who is not predisposed and, the surgery has gone well and metabolically the patient is fairly stable, still, if you don't manage the pain, it is well known that the patient can actually develop delirium. If there is infection and if it invasive devices naturally, if the patient is immobile for a long time and you fail to mobilize the patient soon enough, and then of course, some of the medications that we give, sleep deprivation, if you frequently wake up the patient, even in ICU setting, in ward setting, frequently waking up the patient to give medications, do procedures, then the patient might be at risk. If the patient does not meet family, there is lack of communication, and particularly this is very relevant in general medical setting and in psychiatry setting. If you sedate the patient due to any reason, and if you have applied physical restraints, the factor itself might actually predispose the patient to develop delirium. Why does delirium occur? Let's go through this very quickly because it's important for you to understand the basis of using some of the medications that we have to treat delirium. So we discussed about how certain people, if you look at the previous slide, so how certain people who are elderly with dementia, with low educational level, with comorbid alcohol or drug abuse can be predisposed to have delirium. It's because there are three underlying factors. They have impaired noradrenaline and acetylcholine neuronal connectivity in the brain. And you know that noradrenaline and acetylcholine is required to maintain consciousness and alertness. And when the brain has a degenerative disease, we know by pathology that astrocytes and microglia have been primed. And if they actually experience an acute insult, they would actually be very quick to themselves produce inflammatory, inflammatory substances such as interleukin-6 and all these, the acute inflammatory agents. Then, of course, with age and with degenerative diseases, you find that the brain vasculature has changed and there's impaired perfusion and the blood-brain barrier is leaky. So, these factors now predispose a patient to systemic triggers, like there is some infection with inflammation, and we know that when a patient is sick, the brain needs more oxygen and more glucose. And if there is infection, if there is some metabolic derangement going on, we know the brain would actually now suffer from hypoxia and either hypoglycemia, and hyponatremia is another very significant cause, and the blood flow to the brain can be impaired. Now, we add on to these risk factors by prescribing medications which increase GABA transmission. So if you prescribe a benzodiazepine on top of that, or if you prescribe an antihistamine, which is famously known to affect the reticular activating system, and anticholinergics again, which reduce alertness, then the patient might actually develop delirium because their thalamocortical circuits, the reticular activating system, and their cortical integration is affected. So this is basically the pathology behind delirium. So what should we really do? Do you think that, noradrenergic medications might be helpful? The problem here is that too much noradrenaline, too much noradrenergic neurotransmission and too less noradrenergic neurotransmission both cause delirium. So how are we going to, achieve some sort of a balance between this? And anticholinergics, of course, we know you prescribe them, then they might actually cause delirium very quickly. And how about, instances where there is alcohol withdrawal causing delirium? We have to give something which, stimulates GABA. So you see how in different patients, we need to tailor the medications and we need to tailor the intervention so that for each patient, it would be different according to the pathology. Now, we discussed several times why we should actually worry about delirium. I mean, when we were medical students, delirium was an acute condition. They developed delirium when there was an acute insult to the brain. Then they suffered, they got better and nothing happened. But now we know that they will have permanent cognitive deficits even at 6 months. And they might not actually be progressive ones, but they will have cognitive deficits, especially elderly. If a patient who already has existing dementia, particularly Alzheimer's or Lewy body dementia, we know that it would actually accelerate the existing dementia. So if a patient develops an infection and goes into delirium, we know that the prognosis of dementia itself is altered by the delirium. And this is really not, the problem is that, there is acute brain injury to maybe due to the infection or the metabolic derangements, but delirium itself is now thought to cause separate brain injury and cognitive impairment in addition to the acute brain injury caused by other infections and metabolic derangements. Then there is this new concept that they would actually suffer from long-term cognitive impairment. We call it LTCI. And the pathology is different from Alzheimer's. So it's different from the amyloid cascade hypothesis, and it shows different pathology with different proteins being involved and hippocampal atrophy. And they, the deficits would be progressive, and it's a different type of cognitive impairment from the usual dementias that we see. So the third patient that we were discussing about, the elderly female who suffered subacute delirium, which was probably unnoticed by the medical staff, probably suffered from long-term cognitive impairment superimposed by the delirium. So this is something we have to worry about, because we know that the possibility of LTCI occurring after delirium is much higher with patients who suffer subacute delirium. So the hypoactive delirium, where the patient is more sedated and drowsy and poorly active with disorientation and poor attention and concentration, they would be more likely to suffer from LTCI. Then, of course, longer term, from 6 months to 1 year, they have looked at the prognosis and found that patients who suffered delirium, when compared to patients who did not, they have higher prevalence of depression and anxiety and PTSD. The PTSD, of course, I'm a little bit querulous about, but then, of course, there is a good evidence base to say that they actually can have a higher incidence of PTSD. So how do we assess in the general medical setting or in the ICU setting? In the surgical setting, it might be very straightforward for somebody who is doing psychiatry, but for somebody who is working in a very busy medical or a surgical ward, it has to be very quick, isn't it? You have to be quickly able to identify somebody who is delirious and do what is necessary. The main names are that you identify a delirium is there, and then how bad is it? What is the extent of the cognitive impairment? What is the level of arousal of the patient? Because, according to the level of the arousal, you might have to either sedate the patient or activate the patient. What is the duration of the delirium? Because, the longer it is, the worse the prognosis is going to be. And what is the level of distress of the patient? Because if you are going to prescribe some medication which might actually alter the prognosis of the disease itself and the delirium and might actually even harm the patient, You want to know how distressed is the patient. If the patient is not distressed at all, then don't prescribe anything. These are the considerations in the assessment. There are many tools. If you go up on the internet, and you will find there are lots of tools to assess delirium. But two of the tools are very often used, and I think if you have worked in an ICU, CAM should be very, you might be familiar with CAM. So it's called confusion assessment method. It has different versions for different settings. So I've given you the example for CAM ICU. If you don't remember any of those diagnostic criteria from ICD or DSM, don't worry about it. What you need is to answer these 4 questions. Is there an acute change or fluctuation of the cause of mental illness? If there is yes, then of course there is delirium. Is there inattention? The 2 tests which are given here is, there is one test given here where they would actually say, look, I'm going to spell out something, and you can squeeze my hand when you hear the word A, hear the letter A. Now, the words given are, easy for us to remember. That's why they have given it. Save a heart, Casablanca, I think this is Upper Debate anyway. So it's like that because you can easily remember it when you're doing it. But another version of the test is to tell the patient, which can be used easily in Sinhalese or Tamil, to ask the patient to start from December and tell the months of the year backwards. In Sinhalese, you say, I'm sorry, I'm not conversant in Tamil, to say, December වලින් පටන් අරගෙන අවුරුද්දේ මාස ටික පිටිපස්සට කියන්න. And if they can actually tell you 7 items correct, then there are no errors. If the person makes even if the patient makes 1 error, then the score is 1. And if the patient either cannot do or makes more than 1 error, then the score is 2. And then, if the score is positive, if there are more than 2 errors, then there is a possibility of delirium. Then altered level of consciousness, this is the Richmond, I think, sedation scale or something. You don't really need to know that in detail. Just assess if the patient has an altered level of consciousness. If the patient at least has some alteration of level of consciousness, then the patient is likely to have delirium. For disorganized thinking, they have a few questions that they ask the patient. So very simple ones. Does a stone float on the water? Are there any fish in the sea? Can you use a hammer to pound in a nail? So you can ask a few questions, or you can actually hold up 2 fingers and say, මම මේ උසලා තියෙන ඇඟිලි ගානම උසලා මට පෙන්නන්න. So even if the patient can't speak, they can actually, obey your command. And use, without telling them, to assess if the patient is understanding, you tell, now do the same with the other hand, and you don't do it and show the patient. So it shows that the patient is interpreting what you are saying, and the patient understands, and there is no impairment of global cognition. So you tell the patient, then ඒ විදියටම අනික් අතෙන් ඇඟිලි දෙකක් උස්සලා පෙන්නන්න. ඇඟිලි දෙක කියලා කියන්නේ නැහැ because you actually expect the person to hold the 2 fingers. So CAM is a very common test. If you look at various guidelines, if you look at various research articles, CAM has been very commonly used. But in your ICU or general medical setting, just check for alteration or fluctuating mental status. Is there inattention? Is there altered level of consciousness? And is there any disorganized thinking? And if so, then the patient is very likely to have delirium. The other test that they use is the 4AT. And it tests alertness and attention. And if the patient actually scores 4 or more on this test, you can actually score that the patient is actually having delirium. So it's very simple, but these tests you need to do. So it's much better to have a clinical judgment, I think, even though tests might actually be more sensitive than you in a hurry and doing this particular test to detect delirium. So it again, is rating on alertness. And you ask the patient for attention, the age of the patient and the date of birth, which hospital they are, and the current year. And you another, for the attention, the test that they give is to repeat the months of the year backwards. And you decide if there is a changing or fluctuating course. Because the score is 4, if there is some clearly abnormal alertness, if there is any acute change or fluctuating course, then they would actually score 4. So that's the most important thing. And you can, of course, formally test orientation and attention. But for me, I think the most reliable thing is, remember, has there been any sudden change in the patient in the level of alertness and consciousness? And, is the patient having some attention impairment and, some cognitive impairment, some global impairment in cognition, and then you decide that the patient is delirious or not. So how can you investigate the patient? Remember, because the causes of delirium are very, very variable, what you need to do is what is relevant. So you probably need to take a detailed history and understand if the patient has any predisposing factors for developing delirium. You can do neuroimaging if you want to, if you suspect if there is a stroke, if there is something else going on in the brain. They say that the commonest finding in neuroimaging was an intracranial hemorrhage. You can do a lumbar puncture if that is indicated, but not all of these things need to be done. So it's more basic investigations. And as most of you are already doctors, I didn't want to actually give the whole list. So the basic, blood investigations, the blood works, and then think about what other relevant things you need to do. Then, of course, things which you might not catch are bladder and bowel movements, pain, any possibilities of immobility, or depression, which is contributing to delirium, and those things you need to exclude. Now, EEG, again, you don't really have to do, but EEG is a useful test because they know that, if there are more significant EEG findings, that the prognosis will be worse. So the findings which have been actually reported, I'm not an expert on EEG, have been occipital swelling and general increase in the slow wave ratios. They also report that there is an alpha decrease and delta and theta power increases, and these might be things that you look into. What are the prevention and management options? Think about the causes. Think about the particular patient and the word to use. If you are a postgraduate trainee, of course, I think you would like what is the evidence-based treatment or management options here. Everybody is now talking about multi-component interventions. Multi-component interventions consist of all these components that I have listed here. And there is now good evidence base from systematic reviews and meta-analysis that multi-component interventions are effective at prevention and treatment of delirium. Basically, the prevention and the treatment of delirium, they are basically the same intervention. So I put all of them here together. Generally, you have to recognize early and screen patients for delirium, and that's one of the management strategies. So you need to make sure that you identify risk factors, the predisposing factors in somebody who is presenting to you. Then the environmental factors, improving sensory input, making sure that they hear properly, they have their hearing aids with them, they see, their spectacles are there with them, there is enough, sensory stimulation for the body, the patient is aware of the time, and the patient has enough time with the family, and that's very important. Then the other metabolic aspects, hydration, bladder bowel output, diet, nutrition, those things. And of course, when we say metabolic, make sure that renal, liver functions and electrolytes are in balance. Early mobilization, if it is a post-surgical patient. And another very important aspect is pain management. So ask about pain and manage pain appropriately. Sleep is very important. Maintain a regular sleep-wake cycle. Prevent people from being woken up too often for, interventions, medications while they are in the ward or even in the ICU. And avoid as much as you can, avoid antipsychotics and avoid benzodiazepines. Why, we will, discuss later. So drugs, we know, actually can worsen delirium. We know that lots of anti-adrenergics that we give, anticholinergics that we give, antipsychotics that we give, sedatives that we give, GABAergic medications, they can actually worsen delirium. But I mean, you can't do without medications sometimes, because we know sometimes a patient might be very restless and agitated, and you might not be able to intervene at the underlying root cause if the patient is too agitated, and you might not be able to put an NG, you might not be able to put an IV line. So therefore, you need to manage the patient's distress also. But remember, none of the pharmacological treatments have a high level of evidence other than pharmacological management of the root cause. So if it's an infection, yes, antibiotics. But if you give something to manage the distress of the patient, to sedate the patient, calm down the patient, none of them have high level of evidence, and almost all, they don't have any significant evidence in prevention of delirium. So there have been many trials on haloperidol and acetylcholinesterase inhibitors for prevention of delirium, but up to now, there is no evidence. So if you give haloperidol, expecting delirium for a patient post-surgical, there would not be any benefit. Acetylcholinesterase inhibitors might actually have, such as, cholinesterase inhibitors we use in dementia. So there is some evidence that for patients with Lewy body dementias, you might actually reduce the risk of delirium, but not generally. You can't actually generally use cholinesterase inhibitors for delirium. So giving any of the medications do not have any evidence on the primary outcome for the delirium. And the funny thing is, there's one medication, I'm not familiar with this at all. Maybe you can tell me if you are working in the anesthesia sector, or if you are working in an ICU, if you have used this dexmedetomidine. It's an alpha-2 agonist, alpha-2 adrenergic agonist, similar to clonidine. And there is some evidence that in mechanically ventilated ICU patients, that if you use this medication when compared to patients who were not on dexmedetomidine-induced sedation, their actually outcome is better in terms of prognosis at 6 months. So they might actually do better than other patients. So this is the only medication which has some evidence base that it actually alters the prognosis, and none of the benzodiazepines or antipsychotics have any evidence base, and nor does acetylcholinesterase inhibitors. But, we cannot do without, antipsychotics or benzodiazepines at times. So what are the principles of prescribing these medications? You have to prescribe them only if the patient is distressed and it is a management problem. So remember the first patient, yes, maybe a small dose of an antipsychotic. Remember the second child, if the mother is able to manage the distress, is able to contain the child, don't prescribe anything. The third patient, don't give anything at all. Patient is having hypoactive delirium. Patient is not a management problem. She will take whatever is given to her. Hydrate her, make sure that she sleeps okay, mobilize her as soon as possible, treat the pyelonephritis, and she will get better. The other principle is don't prescribe to alleviate physician's distress. So sometimes, when it is a delirium, the treating physician, I find, is more distressed than the patient. And sometimes when it is delirium, we kind of think that, should we write a medication or not? And this is something, even as a psychiatrist, when I go and see a patient, I find it a little bit odd that I've seen the patient, but I'm not writing anything and I'm coming away, and it kind of makes me feel a little bit bad. But, don't prescribe anything if the patient does not need anything. Avoid benzodiazepines in all patients unless it is alcohol or substance-induced withdrawal. So benzodiazepines will actually worsen the delirium if the cause is not alcohol or substance withdrawal. In amphetamine withdrawals, in alcohol withdrawals, opioid withdrawals, if the patient is delirious, you can actually prescribe benzodiazepines because you need to manage the GABA withdrawal. Avoid anticholinergics at any cost. So sometimes if there are no extrapyramidal side effects, so even if there's a little bit of EPSC, you don't need benzhexol. And if you write benzhexol, then actually the patient might actually become more confused. So what can we write? Haloperidol and olanzapine are the two famous medications which are prescribed. But if you go through NICE guidelines, they will actually say only haloperidol, and from 2019 they have advised not to use olanzapine. Why so? It's because of their regulations. Olanzapine is not recommended, it's not registered, I think, officially for delirium in UK. So therefore they say use haloperidol. For us, of course, using haloperidol is quite good. Olanzapine is out of stock in NHSL anyway these days and in almost all the hospitals. Use a small dose of haloperidol. Start with 1.5 milligrams. If you have 1.5 milligram tablets or 2 milligram tablets, or if you have 5, break it into 2 and prescribe a very small dose of haloperidol first, and you can titrate it very gradually. Sometimes patient might be very, very agitated and restless. Try not to use intramuscular preparations. I know few patients in real life who actually died because they were given intramuscular haloperidol. So people who had some small infection, they became very delirious, they became very restless. The first dose of haloperidol was given because they were restless, and the delirium worsened. And the treating doctor actually thought that it's the delirium is worsening because of the root cause, and gave another dose of haloperidol, and the patient actually, absolutely collapsed. So don't use intramuscular preparations unless absolutely necessary, especially antipsychotic preparations. But if it is alcohol withdrawal, if it is substance withdrawal, yes, you can actually, if the patient is too restless, which happened very recently for us in one of the CL patients, you might need to give a benzodiazepine and sedate the patient. It will work for the alcohol withdrawal, and it will work to sedate the patient too. Consider the likely neurochemical and liver kidney dysfunction. So if the patient is having liver impairment, you might actually prefer haloperidol over olanzapine, because haloperidol is a little bit more safer than olanzapine when there is liver impairment. If the patient is having, what is the neurochemical abnormality? If it is alpha, surge, like in, alcohol withdrawal, you might use something like clonidine. Think about this new medication. If you have access to it, I would like to know if anybody has had any experience over that. But never ever anticholinergics. don't give antihistamines if the patient is delirious, because again, that's another medication which will worsen the delirium. So small doses of antipsychotics. If you don't have access to haloperidol or olanzapine, maybe you can use any other antipsychotic in very small doses. Things we have used are chlorpromazine, very small doses like 25 to 50 milligrams at a time. Then gradually titrate it to the level that you need to calm down the patient. Maybe even risperidone, but there is not much of an evidence base. There's not much trials done using these medications. Most of it is on haloperidol and olanzapine. And remember, prescription of these medications do not alter the prognosis at all, and they might actually worsen the prognosis. So if you find it very difficult to manage the patient, keep calm, call a psychiatrist. When you have, you might have forgotten some of these things. We might help you to sedate the patient, but remember, delirium is basically a medical emergency or a surgical emergency. It's not a psychiatric emergency. We will come and help you. It's a psychiatric emergency if the patient has been given antipsychotics or antidepressants or something and the patient is delirious. But it might be useful for you to identify if a patient who had been having dementia and you find it difficult to sort out if the patient is now delirious or not, we might be able to help you out there. If it is alcohol withdrawal, remember, we might be able to help you with a little bit more of sedation and some advice, but it's a medical emergency. So therefore, you would be the best person to treat the patient. So I've come to the end of my session. Some of the questions that you have sent to me, I have answered in the presentation. There was one on how to manage delirium induced by carbon monoxide poisoning. The principles are the same. So you manage the carbon monoxide poisoning. You withdraw the patient from the situation, and 100% hyperbaric oxygen is what is needed. The prognosis, of course, I'm not very familiar with the management of the acute medical condition, but would depend on the length of exposure and how severe it is. But the worse the delirium, the worse the outcome would be. And I'm pretty sure after carbon monoxide poisoning, they are very likely to develop cognitive impairment than in other cases with delirium. So carbon monoxide poisoning is very famous to cause long-term cognitive impairment. And some of that might be LTCI, where they might actually go on to develop a progressive dementia. Let's go through the MCQ. It's a medical emergency. Yes, it is a medical emergency because we know that mortality is almost 20 to 30% after delirium. However mild it might be, and hypoactive delirium has worse, mortality outcomes. Best managed by high-dose antipsychotics, false. You have to use antipsychotics as sparingly as possible and the smallest dose possible. Known to occur with subacute onset? Yes, of course. That's one of the commonest presentations, and that's why you might actually miss delirium in a patient, and you might actually send the patient home without realizing that the patient is delirious. Characterized by poor attention? Yes. Along with impairment of the level of consciousness and arousal, poor attention is the hallmark characteristic of delirium. It's common in the elderly, yes. It's common at the two spectrums of age. That's it from me. Thank you very much. I'd be happy to answer any questions if you have. Back to you.
Thank you very much, madam. And there are two questions in the chat box, madam. First one is, what is the IM or IV medication we can give to Alzheimer's or Lewy body dementia patient presenting with delirium?
Yeah, so make sure you do not give do not give any anticholinergics. That's the first instance. Then antipsychotics, they have anticholinergic properties of their own. So particularly, almost all the antipsychotics. So you're actually, going to cause worse, continue the acetylcholinesterase inhibitors if they're already on these medications. If you have to give no IV medications, so antipsychotics or don't give any benzodiazepines. If you really have to, then if oral medications don't work, then maybe a very small dose of intramuscular haloperidol, but it is very likely the patient will suffer consequences. So be very careful of neuroleptic malignant syndrome. The thing is, benzodiazepines, they might actually worsen the delirium, but they might not kill off the patient like the antipsychotics. So you might have to, make a very balanced decision there and, use it sparingly. Can we go for haloperidol IV route in delirium? No. So we never give antipsychotics IV because they will almost 100% cause NMS. So never ever give intravenous antipsychotics. So I know you might realize that chlorpromazine was available when we were doctors, when we were interns. Chlorpromazine parenteral preparation was available. Then mistakenly people used to give IV chlorpromazine, and the patients died. So they actually prohibited chlorpromazine parenteral preparation in Sri Lanka. So we don't have the preparation now. I am going through the chat box. Shall I go through and then answer?
Yes, madam. Yes.
Right. Fluctuating consciousness, digit span test. I think what you mean is that digit span test might be a good test. Yes, it's actually one of the most sensitive tests to identify poor attention. But only thing is, not many people would be able to do the digit span very well. Digit span has a bit of an educational ceiling to it. So therefore, months of the year backwards is a better test for attention. Remember, it is not to test consciousness. It is used to test attention and concentration. Okay, haloperidol. Why specifically we have to avoid IM route? Because, if you give IM, IV, of course, definitely the patient will go into NMS. IV, you can actually use benzodiazepines IV. Sometimes very difficult patients, with the help of an anesthetist, they might actually use intravenous benzodiazepines to calm down a very agitated, restless patient, but not in the usual medical or psychiatry setting. IM, of course, we can use antipsychotics or benzodiazepines. Then
those are the questions, madam. And
yeah, I think that's it.
Yeah, audience, if there is any other question, you can post it in the chat box, or madam, we'll give 1 more minute for the questions, madam.
Yeah, sure. I wonder if anybody has used this medication, dexamethasone. Is somebody who is working in ICU anesthesia? I mean, have you guys used this? It was very quoted in most of the literature. Has anybody used it? There's one thing, maybe I think chlorpromazine dose, maybe. If you don't have access to haloperidol, if you don't have access to olanzapine, you can use very small doses of chlorpromazine. The tablet comes at 50 milligrams. You can break it into 2 and start off at 25 milligrams. Don't go beyond 100 milligrams because chlorpromazine is associated with very high risk of mortality due to sudden cardiac death. So basically due to cardiac arrhythmias in somebody, which usually happens with people having mental illness at higher doses, maybe beyond 300 milligrams. But in somebody who is having delirium, they are very likely to have these problems at a very small dose. So if you don't have any other choices, yes, maybe a very small dose of chlorpromazine might be useful, but at the risk of monitor the ECG. monitor the blood pressure. Right. Okay. So somebody is saying that dextromethorphan is commonly used in ICU setting. So you give it as an infusion, calms the patient down and gives smooth outcome. So I'm very happy to hear that. Most of the literature says that it's the evidence base is almost, completely in patients who have been on mechanical ventilation, and they say that the medication gives the outcome is better for patients who had been sedated with dexamethasone, whatever dex they call it. The outcome is better with that when compared with patients who were not sedated with that. But it's a alpha-2 adrenergic agonist, so it reduces noradrenergic surge, which is usually in, we see it in alcohol, we see it in opioid withdrawal. In other forms of delirium, I'm not very sure, but usually agitation, restlessness is usually associated with noradrenergic surge. But it may be hypoactive delirium, you should not give it, probably because they probably would be having noradrenergic deficiency. Right, thank you very much for that. I didn't actually know that it was commonly used in Sri Lanka. Is that all then?
Yes, madam. Thank you, madam. And thank you for clarifying those queries from the audience. And yeah, madam, there is another one more question, madam. In Parkinson's and Alzheimer's, patients with delirium is levonorprazine preferred.
You can use it, but again, just like it will be less likely to cause problems with so levopromazine is promethazine, isn't it? I hope I am correct. I am matapi nama vediya familiar na. Would you be able to clarify? That's promethazine, isn't it? If it is promethazine that you mean, phenothiazines, okay. Phenothiazines can be a group of medications, but so chlorpromazine is one of the phenothiazines. Promethazine is again a phenothiazine. We usually use it in our setting to help a patient sleep if they're having delirium. Again, giving haloperidol, none of these medications have any evidence-based. They say that it doesn't, change the prognosis. Promethazine is less likely to cause problems than either chlorpromazine or haloperidol. So you can actually use it better. You can even go for a bit of a higher dose, like maybe even 100 milligrams. And that might actually work out for patients. And it's less likely to give a bit of give a hangover the next day, unlike benzodiazepines. I hope I answered the question, and I'm not familiar with this name, so I think it is phenothiazines that you meant.
Thank you, madam. And I think we have come to a conclusion of this session. And our sincere thanks to Professor Madhubhashinee Dayabandara, consultant psychiatrist from Faculty of Medicine, University of Colombo, and National Hospital of Sri Lanka for her excellent lecture and her precious time. And I would like to thank the audience to participate in this webinar. And find the link in the chat box. Kindly give your feedback and answer the post-assessment questions to receive your e-certificate for participation. And we hope you had a productive session today. We invite you again to next week for another interactive and timely topic in our SHRI webinar series. Once again, thank you very much, madam, to share the knowledge with us. Thank you. Thank you, everyone.
Thank you.